Mm.
Um, Good evening to one and all, and thank you for giving me this opportunity to spend this 1.5 hours with all of you. Um, so today we are going to look into a very important topic of palliative care in non-cancer illnesses. And somewhere today, I think we'll see that probably palliative care is much more important in non-cancer illnesses, if not as if not more for cancer-related illnesses. So I would request everyone as much as possible to turn on your videos so that I could interact with all of you, see you as well, until unless you or I have internet issues. And please feel free to use the chat box to give responses as much as you can, so that it becomes as interactive as possible. Right. So with that, we'll move ahead. And I just want to revisit a few things which will set the tone for today's session. So, one of the common questions which is asked is, what is how is palliative care relevant in non-cancer illnesses? In cancer, it's understandable also because it has been marketed well in the world of cancer. But when it comes to non-cancer illnesses, there are so many, different specialties which is involved. And how is it that palliative care as a separate specialty comes into picture? And that is when we'll have to revisit certain things which I'm sure by now in the course you have already seen. So what is the objective of palliative care? If you want to unmute yourself or you want to use the chat box, either way is fine with me, but I want responses from your end. What is the objective of palliative care? It doesn't have to be a long answer. It can just be few quick statements or keywords. I can see some faces. Okay, yeah. So, Dr. Gauri, to mitigate suffering and improve quality of life, enhance quality of life, to alleviate suffering, improve quality of life of patients, alleviate suffering. Great. So we are all on the same page as far as it is concerned that the objective of palliative care is to probably mitigate suffering. So if you look at what is palliative care, this is something which already you know. It is the active holistic care of individuals with serious health related suffering. So this is something which all of us know by now. And what is serious health related suffering? Anyone? What is, if you have to explain to somebody, one of the commonest issues which we face is what is serious suffering? Term. What does it include? Some responses. Somebody wants to do so as well. What is serious health related suffering? Now, I know you would have known these things already, but this is important as we move forward in today's session. Okay, pain. Dr. Ardra is saying that is pain. Cancer related pain. Okay. Chronic illnesses. Okay. I think for many of us, even if we do not have an illness, still there can be pain, right? Due to various reasons. Yeah. Do you agree? Financial suffering, Dr. Gauri, yes. So different kinds of pain. But there are certain definitions which is in place, which is going to help you to actually streamline it a bit.
Your voice is breaking a bit, Deepak. Is that right?
Yes, ma'am.
Sorry, is my screen visible? I think it's gone once again.
And also you have your video off. And then.
Sure. So there is some definitions which is in place for serious health related suffering as well, which is going to help you to use these definitions to see which all conditions come under the scope of palliative care. So what is SHS? It is health-related suffering is serious when it cannot be relieved without medical intervention. So we are saying that we need medical intervention, which means you may have to take the support of different specialties in the field of medicine. And when it compromises physical, social, spiritual, and or emotional functioning because of a severe illness. So now we are bringing back the WHO definition as well. That is, there is multiple dimensions to this. And there is a definition for severe illness as well. So what is a severe illness? It is something which can cause high risk of mortality. It negatively impacts the quality of life and daily function. Mark these words. Okay. It negatively impacts quality of life and daily function. And or is burdensome in symptoms, treatments, or caregiver stress. And it is more so in the case of people who are end of life. Now, when you look at these three definitions, do you feel that cancer is the only illness which brings about these adversities in a person's life? Can you respond on the chat box? See, cancer maybe, right now has become such a big issue as a public health problem it is becoming into. And the treatments are uncertain. So definitely it has got those implications. But even illnesses which has got known treatments may not be fully cured, but the symptoms can be managed or the illness can be controlled. But these people are impacted over a period of time for many years together. A simple example is diabetes. The cost of diabetes treatment, the complications which may be delayed but is anyways going to happen, including loss of vision, loss of renal function, and issues in the nervous system as well. So all these things are going to compound over a period of time. We just use diabetes as an example. We are going to see more. Is everyone on the same page with me till now? Clear till now? Can you please respond on the chat box? Yes, yes, yes. Okay, okay. So let's move ahead then. So the burden of cancer-related illnesses, of non-cancer illnesses, is a lot. There have been studies in India as well, in which it is shown that if you look at this graph, can you see where cancer lies? It is the second last over here. The highest requirement of palliative care in non-cancer illnesses is for heart disease, followed by dementia, frailty, respiratory diseases, neurological diseases, surgical conditions, kidney disorders, and then comes cancer. So this was a study done in Karnataka. But if you also look at global, statistics, there is a big burden or an escalating burden of serious health-related suffering. This was a Lancet report. And if you look at it, these are some of the diseases or categories of diseases which has been put in the report. Now, mind you, these are all non-cancer illnesses. And if you see, there is a specialist for each of this disease. And sometimes even within, there are super specializations also, people who only specialize in certain diseases also. So these are all indicating or telling you that non-cancer illnesses also are life-limiting illnesses. That is, they can reduce or compromise the quantity or quality of life. And it comes as no surprise that even infectious diseases like tuberculosis, HIV/AIDS are also part of it. We are not talking only about physical symptoms here or the complications which can arise out of an illness. We're also talking about health in its holistic
Sorry,
sense,
Deepak, your
which is
voice
what
is
each one
breaking
of
like
us as a
anything.
doctor was supposed to do and is supposed to do.
Deepak,
So if we look into which disease it is going to be out of scope of today's session
excuse
anyway.
me, Deepak, 1 minute.
This is a specialist question.
So there are, as per the Lancet report, these are the illnesses which has been laid down as requiring palliative care intervention at some point in the illness. So you won't be surprised to see that even infectious diseases like tuberculosis and HIV/AIDS require palliative care, because the impact of these illnesses is not just on physical health, but much more on the psycho-socio-spiritual dimensions of health. Now, if you see these illnesses, each of these illnesses has got a specialist for itself. And one of the first principles of palliative care is correcting the correctable. So it goes without saying that many a times in palliative care, you have to take the support of an interdisciplinary team. That is, the specialist doctor is also involved in the palliative care process. So it is out of scope of today's session anyways to look into each of this illness as such. But what we are going to look at is what can be a palliative care approach for non-cancer illnesses as well, which is very much similar to cancer illnesses. Next slide. So where does palliative care come in? Next slide. So if you see this this framework, which is what palliative care is defined as today. Palliative care starts at the point of diagnosis. So as you can see in the slide right now, that okay. Is there a disturbance again?
No, sir, there is no disturbance.
Okay.
No, go ahead.
So as you can see, it begins at diagnosis, and as the disease progresses, the curative care decreases and the palliative care increases. And of course, there is after death also support also. You can see beneath the graph that there is persons with illnesses, there is family, there is caregivers as well who need support or who are supported in palliative care. Next slide, please. So basically, come back. So what happens beyond the four walls of an operation theater or an outpatient department is where palliative care comes in. And of course, some sort of support systems are required. But right now, let's get oriented as to what an approach for palliative care should be. Next slide. So this you already know of. There are multiple dimensions. And officially, it is said that palliative care includes prevention, early identification, and comprehensive assessment of the life-limiting illness. Next slide. So now we are going to see some real-life case scenarios, which is from the field. These are cases which has happened over a period of the last 2 years. And I want all of you to actively participate in this, in these cases as well. So case number 1 is a 27-year-old female. She was recently married and she wanted to become a teacher. She is living with her parents and her husband is also living with her at her parents' home. The husband is a daily wage worker. She was recently diagnosed with Wilson's disease. Wilson's disease is a disease in which there is abnormal copper metabolism, because of which copper is not being excreted through the system. And it accumulates in different parts of the body, including the brain, the eyes, etc. Now, I want you to imagine this scenario right now. She was getting trained in a teacher's training course to become a school teacher. Few months into the course, and she was writing her examination. While she starts writing her exam, her hand starts shivering a little bit. She thought it's probably due to hypoglycemia or exam stress, something like that. And she continues writing the exam. Over a period of the next few weeks and months, this innocent looking sort of tremors of hand starts moving upwards and starts involving her upper limb, her torso muscles, her lower limbs. And today, recently she was in a state where even her jaws starts going into. If she's awake, she's having tremors. If there is some nervous system excitement, as in meeting a new person or meeting people, or she becomes anxious, or if she goes to pick up something from a table, there is severe uncontrolled tremors to the point that she was even finding it hard to chew food and swallow. Her mother had to literally hold her chin and push it up to close her jaw. That is the situation which we found her in. Now, she was being seen by a neurologist and a gastroenterologist for over a year by the time we had seen her. And her she was on certain medications from both the doctors. And the doses were adjusted to a maximum dose. But despite of that, this was the condition which she was in. Now, imagine a 27-year-old female recently married, having big dreams for herself. She is a dancer, actually. She loves arts and crafts, and she makes a lot of items out of these things. Somebody like that who wants to become a teacher is not even having control of her own body right now, except when she is asleep. Remaining times, her body is in uncontrolled tremors. This was the situation which we found her in. Now, I want all of you to get involved and tell me, what are the physical symptoms which you can think of? Next slide. Yes, now I'll wait for some responses. Ma'am, has there been a voice break?
No, Deepak, it's been okay.
All right. So can we look at some of the physical symptoms which I have described for you till now? All of us are senior doctors. I don't want to take names and call people. If you could participate.
There are responses in the chat box.
Yes. So there is tremors, uncontrolled tremors. Sangeet, next slide. Yes. So one of the main issues, yes, inability to eat also. And one of the immediate issues which she needed support for was the severe tremors of the whole body. Okay. Let's look on to the next dimension, which is the psychological dimension. What do you think are the psychological issues or concerns which this person may be having right now? I've given you a brief history. Okay, fear. Yes. Depression. Yes. Debilitating illness at such a young age. Yes. Lack of self-worth, denial. Okay, multiple issues have started coming out. Sangeet, next slide. So definitely she's very distressed about the illness. She has got worried parents. Yes, Dr. Raj, abandoned by husband. So she's always concerned whether her marital life is going to suffer or not. All of us get married, having big dreams in our minds that we want to have a settled life of companionship. And here is somebody at the beginning of which she's having an illness, a serious illness. Finances of the future. Yes, that brings us to the next issue, which is the socioeconomic dimension. Sangeet, next slide. So the family is not having enough income to continue treatments from a specialist. Going in a little bit more, her house is 60 kilometers away in a hilly terrain from the nearest medical college, which is Trivandrum Medical College. It's one of the premier institutes in Kerala. And if she has to travel over there, she cannot travel by bus because it takes time for her to get into the bus, and people give her all kinds of stares. So she was concerned of that. And a rickshaw for 60 kilometers to and fro takes anywhere nearly 1,500 rupees. And in a house where there are two daily wages, the husband and the father, that is, there is not much of an income which they could think of, which they could have. And spiritual distress. Next slide. So that is a lost feeling in life. Like you have described, that there is a lack of self-worth, there is a lot of fear. We are not sure about what all can be done, or the way things may proceed for her. Next slide. Yes, Dr. Gauri, dancing also was an issue for her. Of course, I have not listed it here. Sangeet, next slide.
Just a second.
Yeah. So when you take this approach of really cutting down the issues into the different dimensions of health, we'll get a clearer idea as to how we need to proceed, or what are the interventions which may be required for a person. And this is the only difference which is there between us and between a specialist who is sitting in a tertiary care hospital. So in an NGO sector, we have some liberties because it is an unorganized sector. So we have few liberties like building a team of our own, and engaging with volunteers also. The resources which the community have is always much, much more than any healthcare facility can have by itself. So what are the interventions which we did for this person? So one is, with the help of our social worker, we were able to raise funds and get a super specialist opinion for her. That is, we knew that she was in follow-up, but she had not been going to the doctor for the last 1 year and just continuing the same medications, that is copper chelating agents. And we were not sure, we didn't have the expertise to see whether this is going to be enough. Can we increase the dosages, or is there some other medicine which can be tried? We were not sure of it. So we took a support for the funding. We took the gastro and neurologist opinion afresh, and they told that you have to continue with the same medications. There is nothing else which can be done from their end. That was their final opinion which they gave. All right. The next thing which we did was, we had a clinical psychologist who intervened with the family, counseled them that even though there are issues, there are things which can be done, and we look at those things. So there was a big amount of reassurance which went to the family. And that sessions are still happening actually. And the doctor from his end did some more research, did some more reading. And there was another NGO which was identified for an alternative form of therapy. Now, there is evidence that medical cannabis can be used for neurological illnesses having tremors. Multiple sclerosis, Parkinson's are two diseases in which this is being used often. There was no evidence for Wilson's disease. But for somebody who is as young, and the potential side effects being a little bit of drowsiness and constipation, we thought that why not try this medication for this person? And ultimately, we were happy to find out that with 1 month of treatment, her symptoms came down by 70%. And now she is going forward with the different forms of treatment which is there in medical cannabis. So basically, this is not to highlight the medical cannabis, but this is just to highlight the approach that as palliative care physicians, we may reach a dead end where even medically there may be allopathic medically, we may not be able to see what more to do, or the super specialist may say that this is it. But however, identifying and exploring alternate forms of medicine as far as possible backed by evidence goes a long way, because all we are concerned about in palliative care is improving the quality of life of the patient and the family. And of course, we had volunteers in this region to whom we used to deliver the medicines, and they used to take it to the patient's home and give it to them. So you can see that this itself is an interdisciplinary team. And this is what a palliative care approach is. That is, the doctor, the social worker, the volunteers, there's a clinical psychologist, and even the super specialists were directly spoken to, ensuring that this 27-year-old gets better quality of life. Of course, it is not a 100% solution yet, but she's in a 3-month phase of therapy right now, and she's right now entering the 3rd month. And we are hopeful that with the adjustment of dosages, she may become much better than this 70%. Next slide. Now we are going to look at another scenario. Now over here, we have an elderly couple. This is a growing problem in many parts of the country, where in search of education and progress, the children migrate to different parts of the country and the world, and the parents get left alone. So this is a 67-year-old male and a 62-year-old female, husband and wife. The husband having ischemic heart disease, and the wife recently suffered a stroke. Their children are not living with them. They hardly visit. They are not in a financially well state. So due to whatever reasons, they don't visit often, and they are unable to provide any support for the parents. They live in a remote location. It is a slightly hilly terrain. Now, because of this hilly terrain, this husband is unable to move out of the house and come back a lot, because he gets breathless, exertional dyspnea. He has visited the cardiologist a couple of years back, after which he has just been taking some regular medications which he procures from the local PHC. But because of this dyspnea, he is unable to move out a lot. There is no income in the family except for a 1,600 rupees elderly pension, which the couple gets. The wife, after getting a stroke, has got hemiplegia. She is unable to take care of herself. And this husband is the one who regularly bathes her, washes her after she goes to the toilet, moves her around in a dilapidated house. And like is the case in many below poverty line settings, this house did not have an attached bathroom. The washroom was outside the house. So once a person got stroke, it is even difficult for her to access, to get down the steps during rainy season and other times, to move out of the house. And she doesn't have enough strength in her body to even hold on to a walking aid and go. Next slide, please. So can you tell me some of the issues which this couple is facing? Next slide. Of course, physically, very obvious. Husband is having breathlessness on exertion. Wife is having hemiplegia. Can you mention few psychological issues? If somebody wants to share all dimensions by unmuting yourself, please feel free to do so as well. Can we have some psychological or socioeconomic or spiritual issues? Yes. Loneliness, helplessness, children not living together to help. Yes. Isolated feeling. Yes. Next slide. Depression. Yes. So they are in severe distress and anxiety that no one is there to support them. If one more episode of health issue happens, they may not be able to survive that probably. There may not be anyone to support them. Financial stress, yes. Next slide. Socioeconomically, they were not able to afford to build a washroom inside. They have some space inside the house, but they do not have the money to construct anything over there. So poor health in old age without financial and emotional support. Yes. Next slide. So they were feeling that there is no purpose in living. Their children are not with them. They are hardly able to support each other. How are things going to proceed? So what are the interventions which we were able to do for this person? Next slide. So here we were able to mobilize something which we called as a food kit. That is a monthly food kit having a ration supply of whatever is the basic needs of a household for cooking. Rice, pulses, flour, oil, masala powders, etc. for a month's worth was delivered through the social worker. And we were able to mobilize funds for the washroom construction inside the house. So the volunteers also had got involved over here because in their locality, they were able to approach a builder. They explained the situation to the builder, and that contractor or the builder was able to give us a lesser quote on it at a discounted price for constructing the washroom. That was forwarded to another set of volunteers who raised funds for it. So that is the extent to which we can support a family like this. The medications of the husband was optimized by our doctor, and we also started him on morphine for breathlessness to reduce the feeling of breathlessness, because of which he was able to support his wife better, because of which he was able to move around the house better, because of which we were able to even discuss with him the probability of doing some work at home which can generate some income. And one of the ideas which we had discussed with him was utilizing his house for a mushroom cultivation, for cultivating mushroom, which doesn't take much of effort. And we even conducted a training session for him. The clinical psychologist supported in providing counseling sessions with the wife, who was especially distressed about having a normal future. And we had a physiatry team, which consists of a physiatrist, a physiotherapist, and even a community physiotherapist who lives in the locality. So once the physiatrist came and visited the wife, decided upon what should be her muscle strengthening and rehabilitation exercises which she needs to do, which was then handed over to the community physiotherapist, who twice or thrice in a week would go to this person's home and make her go through the therapy. So this is all the extent to which we can go when we work as a team. I'm sure that right now it may be out of scope for many of you because we are working in a hospital setting. But again, there are hospitals who are now understanding the importance of addressing the person as a whole and are creating those systems, providing that support which a doctor may need to holistically address health. Is everyone with me till now? Can you give me some responses on the chat box? Are there any doubts, any comments, anything which you guys want to ask or tell? Can you please get active on the chat box and let me know if we are all together on the same page till now? Okay, there are over 70 people here and I get the responses from similar names always. I hope everybody is there with us. Yes, community is very much part of the care. Even in a big hospital where I had studied, which was Manipal, Kasturba Medical College, a 2,000-bedded hospital. They have started engaging in from 2019 onwards. They had started engaging volunteers for patient care as well. So we all are part of the community. There is no question about it. But yeah, let's more things, because I'm sure that there will be a lot of practical questions which everybody has. All right, next slide. So this is a third scenario. Again, this is a non-cancer illness. So there is a 37-year-old male. This case was referred to us from a person who knows palliative care, who doesn't have any illness as such, but he referred this patient to us. He had suffered a road traffic accident, following which he had a right femur fracture. And then right now, when we are visiting him, he is 1 year post-surgery. Despite of the surgery getting over 1 year ago, and the iron rod has been put in place and some plating has also been done by the orthopedician, this person was still bedbound. He can sit up, but he cannot move out of the bed. Severe pain over his right knee, severe pain and swelling as well, with some signs of inflammation. He is living with his elderly mother, with his wife and 2 children. The mother was also sitting behind him on his bike. She had a lower back injury during the accident. Luckily, she was not paralyzed, but she still has some lower back pain. But he, unfortunately, it was not the case, became a severe issue. He was in a financially well-to-do position, but after this incident, he lost his job in the Middle East. He had come for a vacation over here for a 2-3 month period, and it is during this 10 days before leaving Kerala, that is when he got this issue. Currently, there is no income in the family. They're living since past 1 year out of the income which he had generated, and that is being spent. And now, currently, the family is in a financial distress state. Next slide. Yes. Can you come up with what are the physical issues which this person is going through? Yes, pain. Next slide. So he's got severe pain, swelling of the right knee. Yes, he's bedbound due to the RTA. So that is one. Psychological issues. Yes, immobility, Dr. Victoria. Dr. Ajo, yes. Anxiety, depression, denial. Depression and anxiety, yes. Helplessness. Something more. He is living with his elderly mother and wife together. Yes, financial stress, Dr. Priscilla. Guilt, yes. Loss of income. Next slide. So here, I mean, there are many families like this, but issues started happening between the wife and the mother-in-law. Because somewhere there was a blame game which started. The mother had to end up taking care of her son, that is this patient. The husband was not able to look after the 2 children, which frustrated the wife. He is always bedridden. It's like having a disabled person at home. On top of that, taking care of 2 children without an income. And the mother is also having lower back pain, led to issues. And this patient started getting insomnia because of all these issues. How is he going to manage? The house has just 2 rooms. And it's also it's not a well-to-do house. Like, it's not even painted. It has got cemented walls. That's about it. So all these issues are happening within the house, and the mother-in-law and the wife would go into fights, and he's not even able to get up to stop them. This was the issue which started happening. The family started breaking down. Now we are just using this as an example. There are any number of families who face these issues. Now, I want us to think that every time we see patients with chronic illnesses, how often do we think about these things? How often do we ask, spend time to understand the issues? We may not be able to do anything about it. Mind you, there are many issues in our own lives, our own family members' lives, our friends' lives. All these are issues which we may not have solutions to, but we listen to them, we understand them. And here are people who come to us hoping for a solution. And all we tell is the physical dimension of health, how it needs to be taken care of, and carry on. Remaining how to do it, where you should get the money from, what are how to manage it is completely on them. So the world comes crashing on them once they're outside our OPDs. Next slide. So no income in the family, hence unable to afford medical treatments needed. Next slide. And he is distressed if he'll ever be able to walk again, if he can lead a normal life again. Now, this person was again being followed up at a premier tertiary care hospital, that is Trivandrum Medical College. Every time he gets in, the junior doctor sees him first for taking the case. And all they see is, okay, there is an infection. He started on antibiotics and he's sent home. So one of the reasons was that there is not enough beds. His case was not being prioritized because there is no surgical intervention. He was told that to continue taking antibiotics. So he would be sent back home. So he came all the way, he used to spend 1,500 to 2,000 rupees for the travel. Because his leg cannot be bent, they used to take an ambulance and come and go back, which added on to financial burdens over a period of time. Eventually, they stopped visiting the doctor at all because they said that anyways, when they go, it's the same things which the doctor says. There is no point in going. So he was in that helpless and hopeless state. Now, when we came into the picture, what are the things which we were able to do? Now, I want to ask you, what are the things which you would want to do? Does anyone want to unmute yourself? There is no right or wrong answer in this. There are so many approaches which can be taken up in any given situation.
Deepak, one choice is we can just come out of this presentation for like few minutes and see if everybody wants. Sangeet, so that we come out and just anyone like see, as Dr. Deepak said, no, there's no right or wrong in this. What's their opinion? What would they like to discuss? Something like that?
Yes.
Because see, all of you will be seeing these type of patients. We are not, all these are real patients, what Deepak, myself and all, we see on a day-to-day basis. Same, all of you are also seeing. So nothing wrong. You just come up with something, as it said, no right, wrong. And this practical and realistic issues are always there. Only thing, like what to say, it's just moving the burden from one person to another. So nothing could be done by ortho team. So that's it. So this is the maximum that we could do. Be it cancer or be it any illness. Every time cure may not be possible. That doesn't mean failure or anything. That is reality. That's the disease per se. That's all. So what is that? What's your opinion or something like that? Evaluation
Right.
and further.
So we've started getting some responses, ma'am.
Exactly.
Dr. Madhuri, yeah, individual and family counseling, rehabilitation, vocational support, yes.
Reaching out to CSR, there are some ahead of that also, Deepak. Okay, individual and family counseling, rehabilitation, vocational help, go along with the patient, the orthopedician, and get a proper assessment done. Then reaching out to CSR, community-based, stable source of income. Yes, just this point alone, you have to just connect. Okay, you have demand supply. You have someone who needs. You may know someone who is willing to help. As he said, no, in the previous two cases, that how the community chipped in, the extra bathroom or toilet or washroom was built. So like little drops make a mighty ocean. So like that,
Right.
psychological consultation of wife, yes, definitely. Anyone can. Like, see, you saw the first case where as soon as they got married, she had issues. So starting trouble. So maybe in the middle, it can happen anytime. Many things can. And not only something like this has to happen to change, being realistic. That is something. I'll just read the rest. Rehabilitation in terms of getting you to be mobile and out of it. Yes, more rehab support, evaluation, further investigation, managing pain, rehab again, rehab physio, re-evaluation, NGO-based contribution, family counseling, vocational rehab. Someone, Raj has mentioned recurrent infection need to be assessed, may require surgical. Exactly. Swab, like a swab from the wound site or where the infection is recurring.
Right.
Victoria, important point there. Sometimes all the patient needs is to have someone to listen, empathize, and carry a conversation. Yes, nobody has time. I'm busy in my world. I don't have 2 minutes to sit and listen. It may be the whole close family may do that. So that will push them down really very, very badly. Culture-based antibiotic. Go ahead, Deepak, whatever you want to add up.
Right. So wonderful suggestions, and most of, these are the areas which we also looked into. Sangeet, if we could reshare the slide.
Yes, go back. Yes, thank you, everyone.
So now if you look at, I'm glad that all of you are on track to already become palliative care physicians. So if you look at what are the interventions which we did, Sangeet, next slide. So we did facilitate for funds to get a second opinion with an orthopedician. So we actually visited a private orthopedician this time because he would have time, and we sent a person along, and they were able to interact with the doctor and understand what are the issues, what needs to be done, and what is the way forward. So a proper conversation with the doctor happened. That was one thing which we did. Now to facilitate this, we had actually gotten this person admitted in our facility, in our inpatient facility. So sometimes, even though we may not have any active intervention to do from our end, but to facilitate what needs to be done for this person, we may have to admit the person. So ours was a place which is closer to the hospital. So we were able to accommodate the person, and we were able to get the consultation done in a slow manner. There was no need to rush to go back home. That was one. Second is an intervention which we call it as a halfway home. A halfway home is a physiotherapy or a physiatry intervention where there is intense rehabilitation for people with residual physical deficits following a stroke or injuries, which may cause brain injury or spinal cord injuries. So what is done over here is we teach the person to become as independent as possible, as fast as possible. There has been a study which was done in this intervention between ourselves and Trivandrum Medical College with the neurology department, where it was a randomized control trial in which there was an arm which received this intervention and there was an arm which didn't receive this intervention. And it was learned that for patients who, in the arm in which the patient received this intervention, the mortality rate was 0 over a period of 1 year. Whereas in the other arm, there were some deaths which had happened. So we have this facility in our setup, which we were able to accommodate him in for a period of a few weeks. Along with this, we had started him on pain medications and other medications which was required. Yeah, to bring a completion to the first point, the orthopedician did surgically intervene. There was some pus drainage which was done. there was a culture which was sent, and like one of you had mentioned, a culture-based antibiotic therapy was started, which was given during his period of admission with us, along with the required rehabilitation through the halfway home intervention. And this person, within 2 to 3 weeks, actually started walking with the help of a walker. So this much we were able to get him to. He's still under rehabilitation, by the way, not fully recovered, but he'll need some more time because the bone is yet to heal. But finally, since the correct interventions have started happening, we are sure that he will be on track soon. Along with that, we gave the pain medications which is required, and the clinical psychologist intervened with his wife. We admitted, we got the wife as a caregiver for the person, and we started, exploring her concerns and providing her counseling sessions so that her equation with the mother-in-law can also improve. And when she also started seeing that he started walking, a hope started coming in that things can return to normal. So these are some of the cases, and there are many more in the setting which I am at. In Pallium, 54% of our cases are non-cancer illnesses. 46% are cancer-related illnesses. And of course, there is a continuous knowledge building which keeps happening. There are, we need to brush up on our basics regarding multiple illnesses. We need to take support from specialists, from super specialists, and also learn from them so that many of our patients we can start benefiting from what are our learning with these doctors. So next slide, please. So what are some take-home messages? One is that palliative care is a holistic approach. This is the one thing which differentiates us from the usual healthcare, is that we are looking at all dimensions. We are exploring it, and whenever possible, we are trying to do something about it. And we will not be able to do it alone. In a high burden setting or a high footfall setting like a government hospital, it may be impossible to spend even 10 minutes with a patient. And that is exactly where we need to have volunteers, or we may need other staff if the hospital is ready to fund. In the palliative care OPD in the government hospital in Trivandrum, which we conduct, we have a volunteer who comes in every day, who supports with talking with the patient and exploring few issues which the patient has. Sometimes the patient and the caregiver can just vent out, and they actually note these issues down and hand it over to the doctor and the doctor's team in the OPD. Next is non-cancer illnesses always have longer survival rates. They will be surviving for decades probably, and they warrant palliative care to improve the quality of their life. Always explore all dimensions of health. I know that we have been trained. I've been there and done that. We have been specifically trained to hear those things which we need to know about the illness, and we treat the person as a patient. But once again, we need to understand that this patient is a person first who has a world with himself, and we need to explore that world if we need to make a difference in that person's life. And many a times, it is the non-medical interventions which adds to health. And hence, collaborative interventions must be explored by doctors and their teams. So many a times, if we are limited to our chambers, things may not work out as far as palliative care is concerned. But when we start communicating and collaborating with doctors from other disciplines, I'm sure that there will be well-meaning doctors and individuals who will come from that. Now we have plastic surgeons, gastroenterologists, oncologists also who support us with treatments, referrals, cutting down cost of interventions, etc. Different roles they play. And I'm sure that once we start talking to people more and more about palliative care, especially physicians of other specialties, they will understand that palliative care is something which is trying to include them. in patient care and giving more space for the patients to vent out what all other issues are there. Because sometimes they may not be able to address all issues and they may get frustrated. And that is when you need to say, all right, sir or madam, you please give me an expert opinion. The other dimensions, I'll look into it. I have a support staff, I have a social worker, I have a clinical psychologist, I have volunteers. So even if you want to suggest a treatment, and if the patient is not able to afford it, I may be able to do some fundraising for it. So that is what a palliative care approach means and should be done by any person who claims to be a palliative care physician. So I think with this, I'll just take a pause. Sangeet, next slide. Any questions? Ma'am, should I take the questions now or after the case discussion?
See, we'll give them the choice. Like we'll give them few minutes if
Right, sure.
See,
So
if someone has any burning questions, they can ask. See, first, thank you, Deepak. As you started off, no, it's equally important that serious health-related suffering. Like, see, as Deepak said, even today, I've seen 50-50. I've done home visit today, and then the patients whom I saw, 50% cancer illness, non-cancer. For example, neurological diseases, 8 years, 10 years. And the caregiver could be daughter, son, daughter-in-law, anyone. We see varieties, okay? Not that we see varieties. All of you will be having in your own homes. Do you not have aunt, uncle, grandfather, grandmother? All of you have. You might have been carer, you may be carer, or you may become carer. So all that is possible. This is not something to be imagined. So, and we have how to handle patients with suicide tendencies in palliative setup.
right. So this is a problem which we very commonly see, Dr. Raj. And this is where, at least at an initial level, to identify the risk of this is somewhere we need, a trained person. One is that we ourselves as doctors can be trained at least to identify before we can act as referrals, like, as people who refer. We need to refer at the right time. That is one thing. But if you have the support system, for example, a medical and psychiatric social worker or a clinical psychologist, you need to get them to screen the person, to assess the risk. And if you think that just interventions at the clinical psychologist level is enough, because many a times why is there such a tendency is what needs to be explored. And that why usually lies in this. It can be because of unbearable pain. It can be because of some other psychosocial issues which is happening. Because many a times we see that when the financial distress happens, that is when the people feel like ending their lives. It's very common. You may be seeing some newspaper issues, articles also. Financial distress leading to suicide is a very common problem. And many a times what people need is to see that there is some hope, some alternate mechanism which they can rely on, which is going to ensure that they are going to survive in those aspects as well. But having said these things, when you say suicide, if you use the term suicide, a psychiatrist has to get involved as well. Because many a times they may need medicine support as well. So an expert opinion in such situations is very important. Timely referral is very important. If you know somebody, many a times that's a big source of reassurance and comfort to the patient. That when you say that I know this particular doctor, why don't you go and meet him? I'm going to call him up and refer your case to him. It is going to make much bigger, more chances of adherence to your advice than just writing it on a piece of paper and saying referred to psychiatry. And I'm sure as doctors, all of us have a lot of networks. If not, we need to build the network, especially in places where we practice, in the same settings which we practice, or in the hospitals or local clinics around the areas which you practice at. We were recently, there was a project in which we incorporated palliative care in a private hospital. So they called us and they told us they want to integrate palliative care into their setting. And initially, we faced a lot of resistance from their own doctors. We started only with the ICU setting because they thought it is end of life care. But slowly, seeing us and our doctor going around and interacting with multiple departments, we started getting referrals from cardiology, from nephrology, and to an extent now that in the emergency room, their own doctors are self-sufficient in providing morphine-related care, morphine-related pain relief for acute on chronic pain inside their casualty. So that is the extent to which it can go. We have a lot of patients with chronic pancreatitis, chronic calcifying pancreatitis who come in with severe abdominal pain. And many a times their dosages needs to be adjusted. There's non-cancer illness, mind you. And the doctors don't have anything particular to do other than pain relief. So now just imagine having a casualty where, your ER physician is able to do this. So basically, a lot boils down to talking to a lot of your colleagues and creating a system where you take them also into confidence, and issues like this, including suicidal tendencies, can be better handled, even if you don't have a support team of your own.
Thank you, Deepak. First thing is that raising awareness, breaking barriers, because raising awareness is important thing, and then raising awareness at all levels. Many times you may have resistance from our medical fraternity itself. Okay, so raising awareness, then integrating, like see this main thing, no, it's still many things that palliative care is only for end of life, it's only for cancer, it's only done by nurses, no need for doctors. I'm not imagining, I've heard all these terms from my friends and people in other hospitals, I think. So, but it will change. As Dr. Deepak said, the place, what he's telling, is again a private institution. So once they have to see to believe, so then it will improve. And then minimum for palliative care service to run is doctor, nurse, social worker, and psychologist. Then add on, you can have physiotherapists, physiatry, psychiatry, all that are second level. So in this way, if you go each way, it's a multi-disciplinary approach and multimodal management. How to approach, how to manage. Okay. I think that, so we'll go ahead with the case presentation.
Yeah, sure.
But unfortunately, the person who was supposed to present has just messaged Sangeet that she had had some emergency, so she is unable to present. So I'm going to read the case, Deepak.
Sure.
And in this front, I'm going to tell, like, thank you very much. All of you are sending plenty of cases. So from today onwards, what I'm going to do is, I'm going to pick two cases. Okay. I'm going to have one as backup. See, this is happening second time now in this 10 sessions itself. So wherever possible, I will inform Sangeet to let two of you know. So one person will be the person who will present. If that person can't turn up or getting delayed at work or whatever it is, it could be anything. So the second person also will be. So I think that may be a better off choice, because case discussion is equally important. Okay, Sangeet, if you start sharing, I will go ahead. Next slide. Okay. 56-year-old female patient, diagnosis LV dysfunction with ejection fraction of less than 40%. Next slide. Main complaints are breathlessness, severe weakness, and non-adherent to treatment and follow-up. Next slide. Suffering from hypertension and diabetes since 2019, diagnosed with LV dysfunction in 2023. Blood pressure 168 by 157 millimeters of mercury, blood sugar 126, which is random blood sugar, BMI 31.49, and that is just weight to height ratio. Okay, next slide. The medications, patient is on dapagliflozin and 10 milligrams. and chlorthalidone 12.5 milligrams with metoprolol, telmisartan also. Next slide. Psychosocial aspects. Family income is approximately 15,000 per month. Homemaker. Husband is a primary caregiver as well, and he's also the breadwinner. He's a daily wage worker. Basically, what is there is neglected care and diet. So with all this and with the low, with her fatigue and things, maybe her physical activity is nearly nil. And what they are able to eat is a couple of meals, which maybe they're getting it from outside, so it's only fried food. Next slide. Main concern is difficulty in breathing, financial constraints, and care to ensure adherence to all her treatment and other things. Next slide. In summary, basically, a non-communicable disease screening was done. In that screening only, she was picked up. 56-year-old female with a history of hypertension and diabetes. See, this is very, very common because in a condition where livelihood itself is so difficult, who is going to see? Many people think, oh, if you go see a doctor, oh, they'll tell me something and that will add on my living cost. So I don't want to see. That's a common attitude. So that's how she was picked up. And then on top in 2019, and then LV dysfunction, ejection fraction, all were identified later. So, and the current medications, what all she's on, which we have seen. And main thing is breathlessness, because see, ejection fraction is 40, and on top of this hypertension, diabetes, how would at present control, but how it has been, what end organ damage already has happened and all, because she has not been on regular medication. So she has not seen a doctor at all for several months. And next, see, drug complaints. She forgets to take her medicines sometimes. She's obese, very poor diet, and very minimal care at home. Because husband is a primary caregiver and breadwinner. So whether will he go earn or will he look after? So it's a difficult decision to make for him. Next slide. Discussion points. What elements or domains of palliative care is applicable to this patient? How can we identify and address palliative care needs among patients in the community? How can we create a linkage between such patients and the palliative care? See, with all the cases that we have seen, I think now we can just broadly, I will read this once again so that we can have this in mind and go step by step as we did for the previous cases. So what palliative care? Is this patient in need of palliative care, and what can be done? And then how do you identify and address these issues which crop up in the community? And what link can you do, or how can you help this patient? Sangeet, we can come out of this presentation so that we can all discuss.
Yeah, it would be nice if somebody could unmute yourself and just feel free
Yes.
to now. What are your opinions?
So whatever you want to say, no, please unmute and say. Maybe you can tell of everything, or you can tell whatever you feel. It need not be in 1, 2, 3 order. Whatever we brought it as discussion also. You want to say what is palliative care, or what you think how you can connect, whatever. How can you help this couple? That is what.
Dr. Dhanya, would you like to give a try? You have to unmute yourself.
Good evening, sir.
Hi, good evening. Tell me.
Sir, in this case, I've seen that this patient is obese and she's on a poor diet. So I think we can make her diet more healthy, more nutritious, so that she'll get all the nutrients, and something which can help to reduce her obesity also.
Right, okay. So definitely she's obese, nutrition is bad, she's having fried foods, probably because of practical reasons, because her husband has to go for work. There is nobody to cook at home. Because of she's having breathlessness on doing even with a 40% ejection fraction, probably even on routine, doing routine activities at home also maybe making her breathless. So definitely diet needs to improve. She needs to have some amount of weight loss. If a weight loss has to happen, she may have to exert, she needs to do some cardiovascular exercises, which she may not be able to do because of the current cardiac issue. So definitely we need
simple. In that note, chair exercise, sit, stand
chair
exercise.
exercises. Yes.
There are ways out for everything. But these type of things, no, we have to educate. This is patient education and carer education. Good.
Right.
Go ahead.
Okay. Anybody else? Okay, we have some things on the chat box. She needs medical treatment to address the congestive cardiac failure. Yes. So we need to revisit with a cardiologist to see that, is the medications optimal? Do we need to change some medications or adjust the dosages? Is there something more which needs to be started? Is there some other intervention which can be done for her? Is something which we need to look at. Dr. Adira is saying she is in need of palliative symptom management, diet counseling, proper communication to know why she is not exactly. Now, this is one question which all of us have to ask is why something is happening. Even when Dr. Raj had said about suicidal tendency, the first thing we need to explore is why a person is not doing or doing certain things before we assume that, yeah, it's obvious, which is because of this that the person is not able to do. So in that case, over here also, we need to explore why is she not adherent? Is there a component of, she is having some sort of a memory loss, or is it just like she doesn't like to take allopathic medicines, or something else? She's not able to, many a times, the patients are not able to make out which drug to take. It can be as simple as that. They have it laid out in front of them. So then they have to identify using the shape and size, the shape and color of the pills. So then somebody may have to just break it and keep it in 3 separate packets, like a morning packet and an afternoon packet and an evening packet. So which one, she needs to take at what time? So we need to explore that aspect. Yes, very correct. Anybody
And
else?
sometimes some medication, some side effect. See, that side effect, could be overcome.
Correct.
So that like taking an empty stomach, taking something like that, or someone might have told something, so no clarity. I don't know, this will help me in this way, or some apprehension. Oh no, somebody took this. Some stories, someone with her friend, family, someone will be telling something. Oh, they told this is not good, this color. Sometimes they say green tablet, white tablet, pink tablet. All that happens.
Yeah.
So looking into why there is non-compliance is very, very important.
Correct.
Maybe many times no money to buy medicine. I have heard this many times, because the same money, whether I'll buy food or buy medicine. So I'll tell them in those cases, you have to find out where the same medicine is available at lower cost. There are so many schemes. So direct them to that place. So you need to have food, you need to have medicine. So find out how to do proportioning of their own income in a better way, so that don't for 10,000 tablet you can get it another place for 4,000. Go to that place, because it should be a reliable place. So there are some schemes and things like that which you can explain and they can go get. So that could be a reason also why no money, not buying medicine.
So just adding to what ma'am had just mentioned, many a times we see, even though there are medicines available in the PHCs, or the primary or the secondary health centers, it is not always available. And sometimes when the person goes, they'll say, today we have telmisartan, we don't have metoprolol, or we have metformin, we don't have the other one. So come back after 1 week. This kind of thing happens a lot with the public health sector. And many a times we need to, probably connect them to some other source of medicine, which can at least be regular. And if they are buying it, like ma'am said, from some places, right now there is this Jan Aushadhis, which is a central government thing where 30 to 70% reduction, you get medicines for that. And I think it's pretty reliable quality also. I know there are some controversies related to whether the, generic medicines, are they good enough or not? But I'll tell you factually, for my father, I mean, we are people who are, God's grace, we can afford medicines, but we end up buying things from Jan Aushadhi only, because there is a 60 to 70% reduction in the cost of it. and his HbA1c levels are below 7 constantly. So I'm happy with the treatment. So basically, these are things which we may have to have a keen eye to look at the prescription. Is the doctor prescribing a particular brand name which is becoming too expensive due to whatever reasons? Do we need to alternate it? Right now, I saw that some medicines is combined over here. So there are,
Exactly.
if you separate the medications, the cost also comes down many a times. Combinations are usually more expensive. So these kind of small things can make a difference for the person's life.
Thank you, Deepak. See, exactly that's what even this, what I read, no, that first tablet, yes, it is something which works for cardiac and diabetic. But that is very expensive. Okay. And one very good example what Deepak gave. See, many feel that, oh, that means medicine. If something is keeping your HbA1c below 7, then it is working properly. So there is clear evidence base there. So what more you want? So only if we tell like that, that can give. See, as he said, no, go to this doctor whom I know. See, you can take this medicine because I have used it and I have found it to be useful. So they will have faith and belief in that and go buy it. So, and then these medications also, no, writing some prescription which is very expensive, that's not the only way out. Okay, if you rob them of that money, whatever they have, if they go and then if they have to go starve on their meal, that is also not fair. Okay,
Right.
so we have to look at all this.
So is there anything else? Like probably there is one more thing. I'm not sure if the sessions are over, but is there any other intervention, medical intervention, which we can try from our end to reduce the breathlessness?
That session has not yet happened.
Okay, fine. Okay, thank you, ma'am. So basically we may look at, once we have looked at all the correctable factors from a cardiologist perspective and the medicines have been managed, we may want to add on a small dose of morphine for this person also, because it will reduce the work of breathing. The perception of breathlessness comes down with morphine. I'm sure there are more sessions which will be coming. Yes, Dr. Adira has mentioned morphine for breathlessness. So that is something which we may want to explore for this person as well. Anything
We
else?
will have a session on it, and that has a different dosing and things. It will be covered in respiratory management.
Right. Anything else? So one thing which I may want to explore is that what is the community setting in which this person is living in? Do they have neighbors? Do they have supportive neighbors? Is there somebody else who can support them, either with the cooking or with the medication giving or with reminding her or with helping her to do some simple exercises at her home, sitting on the chair? Is there something like that which is possible or not, is something which we may want to explore? Of course, you as a doctor may not be able to get up from your chair and go over there, but this is where the importance of us having a network, or having a collaborative working system. There are other NGOs or community-based organizations, self-help groups, well-meaning individuals who work towards, improving the quality of life in different aspects of a person's, life. It may be something to do with a vocational rehabilitation so that they get more, income, or it may be somebody who is providing them free medications, or who is there to guide them regarding some other aspects which they are facing. So this is something which we need to explore beyond what is happening within our OPDs and operation theaters as well. How long can a community support be sustained? As long as there are good willing people in this community, that much long we can sustain it. It is only a question of directing. See, I know that all of us want to do some or the other good for people. I'm sure if I ask, all of you would want to do it. The only question is that we may not have the time and resource to do it. That is exactly why we need to involve more and more people in it. Now, one example which I can give you is, if I have 5 volunteers, okay, and I go to a particular place or a particular area where there are patients once a week, then I will tell the volunteer, can you come on the first Wednesday of every month? And to the second volunteer, I will tell, can you come on the second Wednesday of every month? So for that person, it is only 1 day per week he has to get involved with. Okay. But at the same time, there is continued community engagement. So it doesn't have to be burdensome for the community people. At the same time, you will get to orient more and more volunteers. And once they start seeing that they are making a difference, they will do a much better job than what we can do from inside a hospital setting. But having said that, I know that that facility is not there everywhere. Despite of palliative care being in India for over 30 years now, it is still new to many doctors. If it is new for doctors, forget about patients coming to know about it. It is still a long way to go. Luckily, 2019 onwards in our medical curriculum, there is palliative care, and aspects of palliative care has been made compulsory. So I'm sure that more of us will learn about this, integrate it further into our practices. And if there is one request, whether you are working in your own private clinic or your own hospital or for an organization as an NGO, whatever it is, whichever setting you are working on, one thing as doctors, what we should do is we have to use our doctor tag to collaborate with as many well-meaning organizations, individuals, other doctors also as possible for the benefit of our patient. Only then will we truly start addressing the issues which a person has. Otherwise, the only thing which we can do is somebody walks in, we can ask for symptoms, write down investigations, write down a prescription, and then they have to fend for themselves. We don't really end up making an impact many a times. And this is something which we see, especially because India is still a country where over 60% is still below poverty line. And maybe in Kerala, the setting which we are in, things are a little different. But of late, I have been going to palliative care facilities across different parts of the country, especially in the north. The conditions are deplorable, and a lot needs to be done in that direction. So this is a team effort, which all of us are in right now. We have to do a lot in increasing awareness, educating fellow doctors, educating patients, and community has got a big role to play in it to support us in the so-called healthcare which we give. So I think
in that front, no, one thing what as Deepak said, I've also been in this one now from 2018. Like every organization, no, you can, one suggestion, like you can get some NGO to come into your organization once a month or once in 15 days, something like that. So which might be helpful. So that is one suggestion, because there are so many people, especially helping in education, many want to do. Okay, so you can just ask them to, these type of group or individual, whoever it is, you can ask them to come one day in a week, one day in a month. So they come to see, and then the person who needs it gets to see. So something like that, you can arrange a meeting place or something, and then it will go from there. See, there are still people, and then the satisfaction, as Deepak said, no, when something is done selfless, you and I cannot tell how it goes. So that is an experience experienced by that person. So who are we to say all that? So how long, how it happens, where it happens, when it happens, all answers you have to see to believe. Okay, so there are things like that. At least we can be a link. So we have someone who needs it. We know someone who is willing. So find a link between them. So that is what is one of the take home, I would say. First, is an eye opener that so much of non-cancer. See, caregiver burden is a very big thing in long-term illnesses. And that caregiver needs respite care. That is having a little break. Because if they are doing continuously, they also need to be looked after. They shouldn't become a patient at the end of it. Okay, so all this are there. So non-cancer illnesses, everything. I would say system-wise, cardiovascular to all system. Like we are all experts in medicine. Every system can have patients for in the non-cancer category for palliative care. So that is one thing. And then how to connect, how all. Remember that total care. And then start seeing in that, and how can I be able to facilitate is something to be important. And just a last check in that chat box. CSR based will have longer sustainability. Yes, There are organizations which do not depend on CSR. Yes, there are so many things. How do we locate, identify NGOs that way? Dealing with, that's what. So identify like in local areas, that's what, have contacts or find out. Like that's where a social worker will be an ideal person. What the social, everything cannot be done by a doctor. Okay.
Yeah.
So a
Apart
social
from that,
worker.
yeah,
Go ahead.
yeah. So just to add to that, there is also a directory of palliative care facilities, which is there in our website, in Pallium's website, as well as Indian Association of Palliative Care's website. But those are basically to do with palliative care. It has got cancer as well as non-cancer illnesses, which is dealt with. But apart from this, we don't have a database where there is, where it is available all at one place. But one thing which we have done is sometimes we have approached the social security mission of the state or of the district and asked them that what are the list of NGOs which is there in this particular area and what are the domains which they deal with. It may be education, it may be housing support, it may be sanitation, so many other aspects which at the end contributes to improving the quality of life. So that is also one of the ways by getting in touch with the local self-governments, and they will have a list of NGOs which is functional in that particular area. Also, there are summits which happen, like NGO summits. Somebody was asking about corporate social responsibility. There are CSR summits, annual CSR and annual NGO summits which happen, in the country. So these are things which we may want to keep our eyes and ears open to.
And then the social worker, MSW, medical social worker. I don't know whether that is what is available in Kerala, is not there in other states, because I am also from a different state. So I have not seen as much social MSW involvement what I see in Kerala in other states. So first, raising awareness about social workers. Many things are there, like from women rights. There are so many things, like that social issue, social worker, that thing, is not the same across India. So slightly, slowly raising awareness on that and having them as part of your team will be very, very helpful. Because see, as he said, all government hospitals are overworked. They are telling, many people say, we don't have time for all this. Why are you bringing more work for me? So they don't even want to talk to me. Okay, so involving a social worker will be very helpful and handy in these situations. Okay, thank you everyone. Big thank you to you, Dr. Deepak. Over to Sangeet.
Thank you, ma'am.
Thank you, Dr. Deepak, for the wonderful presentation. Thank you so much. Thank you, Radha ma'am, for facilitating session and reading out the case presentation for all of us. Thank you all for joining the sessions. Thank you. Let's see in the next sessions. Bye.
1 minute, Sangeet. I think Dr. Akanksha just joined at the last minute.